So today we are going to discuss about fundamental concepts of enamel and dentine adhesion. So adhesion is simply defined as joining together of two independent materials for which contact is maintained without the aid of external force, or in more funny way, when two or more adherents adhere together by an adhesive is called adhesion. Here we are being introduced by rather four basic terminologies which are important to understand before we move forward. We have adherence. It means the material, the surface to which we are going to join the other surface. These are the two different adherents. In between them, we have an intermediate layer which is joining the two adherents together, and the whole process of joining is called adhesion. Applying to give you the analogy of Scotch tape, consider that you have one surface, or it's a substrate, or it is an adherent. On the other hand, you have a Scotch tape, which is composed of an adhesive and a polymer material. When you stick to relatively a different surface, it just joins to the different surface, and the adhesive here is playing a role to keeping the two different materials together, joined together. Giving you this analogy that we have an interface and we have an adhesive, can a dental adhesion be possible? For example, we have interface 1 at one end, or the adherent, which could be enamel and dentin. And we have another interface on the other end, which could be a composite restoration, a crown and bridge, inlays and onlays, or it could be a simple orthodontic bracket. So, with this in mind, an adhesive in between is a material which is joining these two independent surfaces together. Not only it is joining, it is also transferring the load from one surface to the other. Okay? So, what can be the clinical applications if we incorporate the dental adhesion? We are relying less on the needs of mechanical retention because we are achieving everything with a thin layer of adhesive. So we are conserving a lot of tooth structure. For example, if you have a 1 millimeter lesion and you want to do amalgam, no matter what, you have to perform a 2 millimeter deep preparation in order to give a perfect retention form. So you are conserving more tooth structure when you are utilizing dental adhesion. And between the restorative material and the tooth structure, the adhesive itself is reducing the micro leakage, the sensitivity, and as well as the marginal staining. And we can perform a static restorative treatment if we utilize dental adhesion. And not only this, we are also transmitting and distributing all of the functional stresses in a restoration, unlike amalgam, which is just dissipating in its surrounding. Uh, so we have a potential to reinforce a weakened tooth structure. So discussing the type, what are various types of bonding mechanisms? We have a mechanism which is called a mechanical bonding, in which there is the interlocking just because of the surface irregularities. Okay, we have a chemical bonding mechanism in which the bonding is being taking place at the very atomic level between the electrons of one molecule to the electrons of the another molecule. So it is by definition is the strongest one. And then we have a weak van der Waals forces, or some electrostatic adhesion through the exchange of the ions, which is called a physical bond. To give you excellent analogy of the application of what we have learned in our previous slides, I want you to pay attention that we have one material here which is termed as a normal dentin, and this is one adherent or one interface. This is another adherent, another interface of restorative material. And between them, you can recognize we have a layer of adhesive. With magnified view, you can see interlocking patterns. The channel and network is taking place between by the advent of maybe the physical, chemical, or mechanical bonding. So this is termed as hybrid layer. Okay. So understanding this illustration here, you can appreciate that this is a dentin surface. You can see the dentinal tubule and the intertubular dentin and the peritubular dentin. And now consider this. When you penetrate the resin monomer or the dental resin inside, it is in the liquid phase, which can penetrate inside these tubules. And when you cure them, they become hard, they become solidified. There is a phase change. They become solid from liquid phase to the solid phase after curing. And when they become cured, when they become solid, so what they are doing, they are creating extension inside these tubules. In this illustration, all of the dentin has been removed, only leaving the resin tags, so you can understand the pattern. So it means that the resin basically penetrated inside these tubules and creating a mechanical means of retention in the dentinal tubule. And this hybrid layer, there could be some weak van der Waals forces or actual chemical bonding is being taking place between the adhesive system and maybe the collagen or the calcium and the phosphate ions of the tooth itself. So discussing quickly a timeline. So Bonacore reported acid etching to the enamel, starting with some non-bonded composites, and then acid etching revealed that removal of smear layer is important in order to achieve excellent bonding strength. Then dentine bonded composites were developed separately, and various modifications were done during the course of the advancement. So whenever we are discussing about any bonding system, the system is basically composed of three steps or three different philosophies. Number one is the etching, and number two is the priming, and number three is the bonding resin itself. So the etching procedure is conditioning or cleaning the surface, and at the same time it is demineralizing enamel and exposing enamel rods. In dentin, it is not only exposing the dentinal tubules, but also it is penetrating inside while removing the smear plug. So Bonacore basically introduced that this smear layer is weakly attached to the dentin. When it is completely removed, we can have excellent bonding strength between 20 to 50 megapascals. And the concentration used was 37% phosphoric acid. And the usual application time for enamel is 30 seconds. So what we are doing here, by using acid etchant, we are transforming a smooth enamel surface into more irregular surface. And when we are removing some of the surface molecules, we are exposing more energetic molecules while increasing the surface energy. And it has a great impact when a fluid resin is applied. It radially penetrates into the surface by a Kepler reaction. And during polymerization, it just interlocks inside. And these resin microtags within enamel surface is the fundamental mechanism for enamel adhesion. Okay, so this is the etched enamel. You can see some of the patterns inside. And now just visualize in your mind when you apply a resin inside and it just penetrates inside. Upon curing, it solidifies what it is leaving. If I just decalcify all of this material and just leaving this resin network, you can see that how critically they are interconnected to each other, giving us excellent retentive force. We were talking about a lot smear layer. So what is a smear layer? It is basically a debris which is prepared during the procedure of tooth preparation, whether you are using a burr, a carbide burr, or you are using a diamond burr. So the same debris which is being generated is deposited on the surface. And it is basically composed of hydroxyapatites and some of the altered and denatured collagen. These are denatured because of the frictional heat produced by the burr itself on the surface. So what it is doing, it is filling the orifices and forming the smear plug. Okay, the same smear layer, when penetrates inside the dentinal tubule, is forming a smear plug. What it is doing, it is decreasing the permeability of the dentin up to 90%, but it is allowing the diffusion of water. Okay, so removal of smear layer has some effects. And what are those effects? It will increase the fluid flow into the exposed dentin, which can then interfere with adhesion. And I'm going to explain in the future slides. So what I was discussing here, you can appreciate in this slide the amount of smear layer produced and the smear plug which is occluding the dentinal tubule. And now you can anticipate that this occlusion is preventing some of the ingress and also preventing the permeability of the dentinal fluid here. Another, the smear layer covering the whole surface of the dentin. Here some partial closure of the tubules, a complete occlusion of the tubules. Again, a smear layer and some of the smear plug is being here. Again, this previous, when you remove completely the smear layer, what you are left here is a complete smear layer free dentin surface. The next component of the bonding system is priming. And what do you mean by priming? Priming means that you are converting that hydrophilic surface into hydrophobic. Okay, your enamel and dentin are hydrophilic in nature. Okay, your enamel and dentin are hydrophilic in nature, and your composites and other materials, they are hydrophobic, so they are never going to bond with that. Okay, This is for sure. So for that reason, we have to use certain molecules, or a primer is a monomer or a polymer which is being carried out mixed in a solvent. A solvent could be acetone, it could be ethanol and water, or it could be primarily water. It's used as a vehicle. So when applied on the tooth surface, the hydrophilic component of the primer joins with the tooth structure, and the hydrophobic end of the primer is going to join with the hydrophobic component of the bonding system. Giving you the analogy here, we have the tooth structure here, which is hydrophilic. So this primer has the ability to penetrate inside these tubules because it has some hydrophilic ends. And the hydrophobic ends, they are being pulled together by the means of primer. So you can apply the bonding resin, which is penetrated inside the primer, which bonds with the primer, and the composite restoration then can be bonded on the treated surface. Okay, so this was a quite simple way for the enamel, but when we are talking about dentin, the adhesive materials can interact with dentin in different ways. They can mechanically interact, they can chemically interact, or they can interact in both of the ways. Okay? So dentine adhesion relies on the penetration of adhesive monomer into the network of collagen fibers which was left exposed by the acid etching. You have seen in the previous slides when the whole dentine surface was covered by the smear layer. So what is acid etching doing? The acid etch is completely removing all of this mineral material from the surface, and also exposing some of the collagen. On the other hand, we have glass ionomer and phosphate-based adhesive bonds. They are chemically bonding with the hydroxyapatite of the tooth structure. So in our previous slides, I was talking about to discuss in detail about the criticality of bonding in dentin. Why? Number one, dentin is a living tissue unlike enamel, okay? And it has tubules, it has more organic content. And about uh, these tubules increase in number and diameter as you are going deeper at the level of the pulp. So as you are going deeper and deeper, the fluid flow is getting more extensive. So giving you the analogy that if you have some sponge in your hand and you are filling it up with water, while you are squeezing it by one hand, and you can feel the fluid coming outward, and you are using your magic glue to adhere something on this wet surface. It's hardly impossible to achieve, but there are strategies to achieve that. And the dentin that undergoes these compositional changes, such as sclerotic dentin, it is much more resistant to acid etching, such as the normal dentin. Okay, and the dentin beneath a carious and non-carious cervical lesion has an altered content of the minerals. So what is dentin? It's a living tissue. It's more organic content. It has dentinal tubules, and the tubules increase as we are going deeper. It's an hydrated tissue, and the movement of the fluid is outward, and this is defense mechanism of the tooth itself, because the intrapulpal pressure is always higher and it is pushing that fluid outward, so there is less chance of bacterial ingression inside the tubule. So this is basically a defense mechanism, and we have to overcome that whenever we are trying to achieve optimum bonding. So again, when you acid etch and you completely remove the smear layer, what you are exposed with, you are also exposed with some of the collagen. Okay, some of the collagen fibers, and these collagen fibers are triple helix in structure. A DNA is double helix, so your collagen network, your collagen fiber is rather triple helix, and each fiber is weakly bonded with the other fiber with small van der Waals forces, and they are always upright in nature, like some spiky hairstyle. Okay, so when they are in upright position, they have better interaction with the bonding resin. Okay, and if you over dry the dentine, you are basically desiccating it and removing the excess water. And when the water is evaporated from the dentine, the upright collagen fibers are just collapsed and leaving a very less surface area for the bonding resin to get penetrate. Okay, so that's why you get less bonding strength, and it is never recommended that you desiccate your dentine. Always, always, always keep your dentine slightly moist so your bonding resin can better penetrate and give you excellent bonding strength. So what we have understood, the bonding or the adhesion is better with superficial dentine. Why? Because we have less tubules, we have less water content, and at the same time we have more intertubular dentine, which we know that has more mineral content. So in this illustration we have composite, a bonding and a priming here, and during conditioning this much amount of area was affected during acid etching. So exposing some of the collagen fibers, and the bonding is penetrating inside these irregularities. Okay, so giving you excellent bonding strength. And at the same time, this hybrid layer, remember when I showed you in the beginning, is basically what? These collagen fibers and the bonding resin. There is a chemical interaction between the collagen fibers and the bonding resin. So adhesion is better with superficial dentine. No doubt that there are stresses are being generated at the dentine interface, because when the bond or the composite or the adhesive system is being cured, initially they are in liquid phase where the molecules are allowing them to freely move, but upon curing, these molecules come together, and inherently it is causing shrinkage. So you can never eliminate shrinkage, but you can overcome. And due to this shrinkage, the stresses are being generated at the dentine interface, and we call these stresses due to polymerization as configuration factor, and which is a ratio from bonded to unbonded surface, and which is telling you that how much shrinkage is predicted when you are applying composite to a number of surfaces. The less number of surfaces, the low configuration ratio and better bonding. Okay, so how to overcome? We have to place our composites in increments. and recommended is you have to place in oblique increments, and you have to utilize a bonding resin which is greater than 70, which can provide you greater than 17 megapascals, and greatly you have to utilize, you must have some enamel margins so you can achieve enamel bonding. So let's go to the classification of the adhesive system. The adhesive system is the dentine bonding agent, a bonding agent, a dental bond, or dentine adhesive system, a bond, but there is no jams in it, okay? So in our first generation of bond was based on the method where the calcium ions were chelated on the tooth surface while creating a water-resistant layer. Unfortunately, the bond strength was no more than 2 to 3 megapascals, so it was, of course, obsolete. The second generation was the phosphate ester in the ethanol. Okay, the ethanol was used as the vehicle, so the phosphate esters were chemically bonding with the negatively charged phosphate group in the resin and positively charged calcium ions in the smear layer. But unfortunately, since the bonding was occurring between the smear layer, which is quite weakly attached to the tooth surface, and we know that this smear layer was being produced during the preparation of the tooth surface. And the bonding strength is, of course, because it is totally relying on the smear layer, is no more than 1 to 5 megapascals. The third generation, it contained hydroxyethyl methacrylate, which is a hydrophilic monomer, and it was not good as well. Then comes another system which was initially classified on the basis of steps. For example, you have a hydrophilic tooth structure. We have a fourth generation bonding agent we are talking about, the gold standard in Total-Etch system. This is the gold standard of Total-Etch system. So we have hydrophobic restorative material on the one end. We want to bond it, we want to adhere it onto the other adherent or the tooth structure. So what are the steps involved? It was a 3-step system in which a separate etchant was used to condition the surface. After etching, a priming is needed, and of course this priming, what it is doing, it is converting the hydrophilic surface into hydrophobic, and then a bonding agent is applied directly on the primed surface, and then it is cured, and which gives you the surface for adhering the composite system or other materials. In the 5th generation, which is also called a 2-step system, a separate etchant is used, but the bond has some hydrophilic properties. It had some properties that it can prime and bond the dentin. So it was called the 2-step system. In 6th generation, another philosophy was evolved, which was basically based on the removal of the smear plug completely or partially. Here, this system is partially removing the smear plug. And what are the benefits? We are going to discuss when we will discuss this bonding generation type. So this is basically a 2-step system. We have a self-etching primer, which is a primer is acidic in nature, which is causing the dissolution and exposing the collagen. The primer itself is doing that because it is acidic in nature. And the bonding agent is penetrating into the primed surface. So you don't need a separate etchant in the 2-step system of the 6th generation. It was pioneered by Carrare The monomer they have introduced was the MDP, which is providing quite extensive bonding strength. So this two-step bonding system is having a self-etching primer and a bonding agent. And then we were introduced with the 7th generation bonding agent, or a hydrophobic, a 7th generation bonding agent. This was a single step system in which the etch step, the prime step, and the bonding step all were joined in just one component. So the one system, or a single step system, was capable of etching and priming and bonding all together, and it removed a number of steps, and it can be used as selective etching method, and you can use it as self-etching method. So let's understand the classification on the basis of smear layer and smear plug removal. On the left side, you have a Total-Etch system in which you have to use a separate etchant. Whenever you are using a separate etchant, you are completely removing the smear plug. No doubt it is giving you a reliable bonding. On the other hand, you have a self-etch system in which the primer itself is acidic in nature, so you don't need any separate etchant. So the steps are minimized in the 7th generation, in which only one bottle was capable of etching, priming, and bonding. And what we are looking at here is that the amount of smear plug being removed is not complete, and it is giving us no post-operative sensitivity whenever we are using this type of system. Okay, so let's look at the mechanism of the Total-Etch system. What is going on in the Total-Etch system? We are using the acid etch inside the dentinal tubules. The whole smear plug is completely removed, leaving this empty tubule. The primer is then applied on the surface. The primer also penetrated inside the tubules, and whenever the bond is applied, the bond gets penetrated following the primer, and upon curing you get a reliable bonding. The 5th generation, the Total-Etch system, we have the smear layer, we have the smear plug. When we acid etch, we are again completely removing the smear layer, and we are also completely removing the smear plug. The bonding resin is priming itself. So in the 5th generation, which is quite common a clinical technique, the primer itself is a bond. On the self-etch system, we can see that we have a smear layer and a smear plug. But because the primer itself is acidic in nature, but it is mildly acidic, so it is not completely removing the smear plug, but it is partially leaving, it's partially sparing inside the tubules and preventing post-op sensitivity. And the bonding resin is applied in the 6th generation as a second step. And what we are doing in the 7th generation is a self-etch system. We have a smear plug and we have a smear layer. One component which has the ability to etch, prime, and bond in just one system. And this is going to be the most reliable method in the future. And the 8th generation bonding system, which is being introduced recently by GC, named as J Premium Bond, is also quite effective, and it contains all 3 monomers in just one bottle. So now, what is the composition of these systems? The etch and rinse approach versus self-etch approach. What is a primer based on? The primers usually based on The solvent could be a water, or ethanol based, or acetone based. The adhesive system, which is could be a dual cure or light cure, degree of conversion versus degree of polymerization, and the phase separation. So what is the role of water in self-etch adhesive? Water is added to formulation to ionize the acidic monomer, so they can better penetrate inside the collagen network. And increasing the water concentration resulted in improved acidic monomer ionization and increased depth of dentine demineralization created by the acidic monomer, because they can penetrate better. Regarding the biocompatibility, the interaction of the etchants with the dentine is limited to the superficial area only, 1 to 7 microns, no more than that. It is unlikely that the acid can be directly responsible for any pulpal injury. The effects of etchant on dentine are limited by the buffering effects of hydroxyapatites, which are being leached out and continuously buffering the immediate surface which is in contact with the etchant. So it is prudent that whenever you apply the etchant, you always rigorously scrub, so you may better get a uniform etching surface. What is microleakage? It is defined as the passage of bacteria and their toxins between the restorative margins and the tooth preparation wall, which can lead to secondary caries, and the pulpal response to restorative material is related to the degree of marginal leakage. Bonding to the resin to enamel is still the best way to prevent the microleakage, because we know that in enamel it has more mineral content, and the locking pattern is excellent in enamel as compared to in dentine. What is nano leakage? There are certain small porosities in the hybrid layer at the transition between the hybrid and the mineralization dentine, which sometimes allows the penetration of quite small nanoparticles of silver nitrate dye. So if they can pass through, so we can term it as the nano leakage. As you can see in this unaffected dentine, the hybrid layer, and the penetration of the dye through that, in this area you can appreciate this is the nano leakage. Clinical factors in dental adhesion. The mineral content of the dentine increases in different situations. For example, aged dentine beneath the carious lesion may be sclerotic, and in conditions of non-carious cervical lesions. Okay, so you may require more acid etch time in these situations, because the dentine in these areas are sclerosed. What are the expanded clinical indications for these dentine adhesives? We can use as desensitization. Why and how? Because these bonds, they can be used to treat the hypersensitivity of the root surface. You just apply on the surface, and it occludes the tubules, and upon curing it just forms a barrier, so nothing goes in and out. So that's it for today. We will discuss some of the composite overview in context of the fundamentals of the aesthetic dentistry, and what types of composites are indicated in certain types of situations. So this is going to be our next session. Any questions, please drop your questions in the class group on WhatsApp. Thank you so much. Assalamu alaikum wa rahmatullah.
ادعمونا بلايك للفيديو واشتراك بالقناة، فهذا يدعمنا كثيرا.